Hello, and welcome to It's Already In You podcast. We are your hosts, Liz
and Janine, nutrition and movement experts, mothers and business owners, obsessed with helping you quiet the noise of diet culture.
Seeing through the false advertising and promises of our food and fitness industries, helping you discover that everything you need to upgrade your health and well-being is already in you.
Hey everyone, it's Liz and Janine. Back again today. We have an amazing guest on. Her name is Magen Price. Some of you have maybe heard of her. She has opened a practice in Melrose, Mass. Called Mystic Valley Sexual Wellness. And we are so excited that she's here. She is a board-certified family nurse practitioner, Menopause Society Certified Practitioner, and she's a certified sex counselor, which I think everyone should be really excited about. I think that must be your favorite part of your job, is it?
It is, absolutely.
Yeah. She does walk around with like keychains that have like
anatomy.
I love that.
Yeah, we'll just keep it at anatomy.
Yes.
I know that she has stickers and stuff that she gives out.
I do. Yeah.
So we are so happy that you're on our podcast today, Magen, and we want to hear what prompted you to open your own practice, and tell us all about you in a way that is not just your bio, but how did you get here?
Yeah, I'm excited to be here. Thank you guys so much for having me. So I've been in primary care, specifically community health primary care, for like 12 years, which is a really long, that's like geriatric for community health. It has a very high burnout rate. And I hit burnout very, very hard last year. I think the way that our current healthcare system is designed, it's just getting people in and out of your office as quickly as possible.
Yeah.
So, I was seeing 80 patients a week, and I have all this great certifications. I have all this great knowledge and training that I've done to really help women overcome these very specific issues, but you can't do that kind of work in a 15, 20-minute visit. With interpreters, because a lot of my patients aren't even English speakers. So, I was not providing the kind of care that I felt like women deserved. I was getting really burned out. I felt like I was never around for my kids. And so, last year, I just kind of had this idea of like, well, what if I just kind of built my own practice? What if I was able to kind of build it so that it was providing the kind of care that women really deserve, and be able to do this training that I've worked so hard to get.
Yeah.
And out of that came Mystic Valley Sexual Wellness, and it's crazy that it's actually here and happening.
Yeah.
Congratulations.
Thank you. Just closed out my first month. It's been so fun. It's been great.
There's a lot of buzz about it.
Totally.
So people are excited.
That's great.
So when you chose, I feel like when you go to school, nurse practitioners, doctors, that kind of path is general, and then you start to hone in on a specialty. Where did that kind of women's health, sexual health, those type of things kind of fall for you?
Well, I think at first I was just, I'm board certified family. So I was seeing infants, I was seeing geriatrics, I was seeing kind of everybody. And within my first few years of practice, I was getting a lot of women kind of in their 40s and 50s saying, I don't really feel like having sex anymore. Like I love my husband. I just don't have where's my libido? Where did it go? And I was just like a deer in headlights. I had absolutely nothing to offer them, right? With men, we're taught like, oh, just give them some Viagra.
Sure.
Right? Which actually doesn't address libido at all.
Yeah.
But, that's what we're taught. And then for women, it's just what? You hear these horror stories of what providers tell women, like have a glass of wine.
Yeah.
Just
relax,
push through it, relax, just go along with it.
Yeah.
And so that was not sufficient for me. And I looked at just doing some basic CME classes, continuing education to try and learn a little bit more. And through that, found the ASECT program, who I'm certified through as a sex counselor. Just fell in love with it and dove in. And it felt like when I started being able to provide answers for women, they were just so excited, and it was so rewarding you don't get a lot of rewarding experiences in primary care. Like nobody's ever given me a hug for lowering their blood pressure.
Sure. Yes.
But
They should.
they should.
Yes.
But it doesn't happen. But helping like a 42-year-old woman have her first orgasm, I get a lot of hugs.
Yeah.
And so that's been really nice.
And I feel like on top of like the woman, like talking women to women, but like, that it's trickling to their like family, their like relationships, their self-confidence, like all of those things that I feel like whether it's not having those experiences ever in your life or seeing them, dwindle down as you get older. And it's crazy because 40 and 50 is not even old. Like we should all still feel like hot and able and capable and stuff. But like when you start to feel those things like sneak away, it can definitely like impact everything.
Although, side note, did you know, have you seen the Golden Girls were like 42?
When that was like filmed.
When that was filmed.
I know,
and
isn't
like,
that wild?
You look at it and you're like, wait a second. I thought they were
know.
like 75 the whole time,
Yes.
right? Like they were
know.
42.
I
Like,
know.
If you think about that, that is crazy.
I think
Like,
our concept of aging has changed very dramatically.
Definitely.
Yes.
And I think the communication around that, I mean, both with like sexual dysfunction, low libido, perimenopause, even just in the last couple of years, I feel like you hear about it. I'm sure my like algorithms, because I'm in that kind of age range, probably like put a lot of information in front of me, but I definitely feel more people are more comfortable. I mean, I'll be in places where a woman will be like, I am in perimenopause. They'll just volunteer the information where I feel like when my mom was at that stage or like people for like years past would have never just openly said it. Maybe they didn't even know.
Yeah.
Yeah. So share like kind of what you see day in, whether it's at your private practice or the community center, community care, women coming in that age range saying in terms of just like where they're feeling in their body, what their symptoms are, what they're kind of experiencing.
It's different for every woman, obviously.
Sure.
Everyone's very unique. But I think in general, the report that I get is just I do not recognize myself.
Yeah.
Not just visually, but I just wake up in a body that I just do not feel right in.
Yeah.
And it seemed like this happened kind of overnight, right? Like I don't know, the way that I digest food is different. My energy level is different. The way that I am responding to the important people in my life is different. I have so many women saying, I used to be a nice person, and now I'm suddenly so irritable. My frustration tolerance has tanked, and, I think that those are those intangibles that historically I think medical providers didn't know what to do with.
Yeah.
Right. And so that's why a lot of women in their 40s get put on antidepressants, because it's kind of this catch-all of like, oh, you're feeling weird and your labs look normal. Here you go. When it makes so much sense that that's a hormonal issue.
Yeah.
And so it's very gratifying to kind of hear these kind of vague symptoms that to me make perfect sense, and to be able to validate somebody and say, yeah, like makes total sense why you feel that way. And let me walk you through why and what are some things that we can do about it to kind of help you feel better.
the symptoms, and you put that list on your presentation, which was like, I know a lot of people in the room were like, wow, like it's like crazy how many symptoms are associated with perimenopause, with menopause. And I feel like so many women think they're just going crazy. And for the longest time, right, they pretty much were told that they were sort of going crazy, right? Even like in your relationship at home, when you would react differently than you used to act, you're getting crazy or you're going crazy. And then you go to the doctor and they're like, here's your medication for being crazy. And,
Exactly.
Right? So I think that the whole like, just you're in this place where nothing's working, everything's changing, no one can help you. It's just take this medication and go home and try to stop being crazy. So someone comes to you and they're having all these symptoms, and it blows my mind, the things that I know now that are happening to me or that have been happening over the past year or 2 years. that I thought, oh, like I'm just getting older, so these things are more heightened, right? Like I think I said I have bridge anxiety. And someone told me that progesterone levels can affect the anxiety that you feel and heighten that, right? Who knew that? But now I'm going over these bridges and I'm literally holding on to the handle in my car, right? And then you see women like move up and start driving in 10 and 2 and you think, like, I remember when seeing my mother first do that, and I was like, what is going on with her? She used to like lean back, do the lean in the car, right? One arm on the seat, just chill out. Right now we're like, I can't see. I'm so stressed. So someone comes to you, and I have to tell you guys that you all know that Liz and I are like, we think that lifestyle is so important, and some practitioners that we meet with, we get frustrated a little bit. Like, we want people to hear that there are a lot of lifestyle changes that you should be focused on and making, and that should be a foundation, right? But when I met with Megan, the one thing that I like really respected and loved about you was that was one of the first things you said to me, like, that's not my background, but I know it's important. And so, and I want you to talk about this because I know that one of your packages includes sending people out to help with fitness or nutrition or more lifestyle changes if they need it, which I think is so respectful, and just it made me smile from the inside out when you said that, because it's so important. It's like staying within your scope and really being able to help somebody, you know, in a bigger way, not just honing in on what you know to be true, right? So tell us about the myths versus all of these symptoms that women are feeling that are real and that really need to be recognized as this is what you're going through, and we hear you and we see you.
Well, I mean, I think that the overall, the umbrella myth, you know, that you just brought up is that you're crazy, right? I mean, I think you go in, you get all these labs done, you get a major workup done. I think Oprah was talking on her special that she went in for palpitations, got this huge cardiac workup, which was appropriate. I'm not saying that's not appropriate, but when all that stuff comes back normal, that is kind of what is left, right? You are crazy. You are making this up. You are, you know, I think what's hard too is that in midlife, especially for women in New England who are kind of starting families a little bit later, you know, there's a lot of overlaying factors. You're probably having kids at home who are going through like puberty, right? Which can drive you crazy. And you are probably, you know, going through a career change, data says, around your 40s, right? You are maybe pursuing, you know, different heights of your career. So there's a lot of obvious stressors that are contributing, and it's very easy for a practitioner who maybe wants to help but doesn't have the right training to say, well, I've done everything that I can. It must be all this stuff at home. So here's what's going on. And I think when you see somebody who has had the training, who knows what's going on hormonally, it's very easy to kind of pinpoint, yes, your progesterone started tanking in your late 30s, long before perimenopause even started, right? And when that drops, you're going to have insomnia. You're going to have new anxiety because those GABA receptors in your brain just aren't being targeted anymore. And so, you know, I think that there's obviously, like you talked about, like lifestyle interventions are so important. You can't really separate the two, but giving you a little bit back of that hormone can be so helpful for even getting you that energy to be able to do the lifestyle stuff.
That's the cycle you kind of get in, is that clients that I've worked with who are in that stage, like like you said, overnight. And even as like a trainer, like I've had people who I've trained for years, and then literally within months they've gained 20 pounds. They're doing all the same, like they're like, I'm walking upstairs and I'm like exhausted, like can't even get enough energy to go and do the things. And when they do the things, they're not even seeing a lot of changes. So it's frustrating, but it really is, there is some truth. And I want to try to explain that. Why does that happen like so drastic? Like you said, it starts for a lot of people probably happening slower, and then, but like what is, and it's not everybody, but what is for a lot of people that like I wake up and I feel like I'm in a different body? Like what internally happens?
Yeah, I mean, I think, like you said, some women, it is a more gradual thing. And for some women, those levels drop off very, very quickly. For some women, perimenopause is over a few years.
Yeah.
For others, it's 10 or 12.
Yeah.
And I think that's very frustrating for both patients and providers because it doesn't give you a very good roadmap. There's not good algorithms for how to treat perimenopause. You can't just follow, if X, then Y. It's very, very individualized because we aren't able to predict who's going to have a fairly easy time, who's going to get through it really fast, and who's going to be spending years, really suffering.
Yeah.
And I think for some women, that drop in progesterone is just very quick, very dramatic. And so they do wake up suddenly feeling very anxious, suddenly feeling very, like they cannot get a good night's sleep. And same thing with estrogen. I think estrogen, we like to think of it as a more gradual kind of decline in our 40s, but I have women who suddenly wake up with hot flashes, night sweats, all of the classic, kind of estrogen deficient symptoms.
Sure.
Suddenly waking up at 45 with a belly.
Yeah.
That they've never had before. And I don't think it's very clear why that happens. But I think that the hormone shifts can be very dramatic, and that can be very, very troubling for a lot of women.
Also think about the time in life that this is happening.
Mm-hmm.
Yeah.
You have aging parents. You have kids going off to college or leaving your home.
Mm-hmm.
Like, there's a lot that a woman is actually dealing with emotionally. I feel like, I think I'm crazy sometimes because my daughters are 18 and 20. They walk out of the house and my brain goes to like the worst possible scenarios. And I have to start to talk myself out of that, you're manifesting terrible thoughts, but you're going through that and you're worried about your parents and there's a lot going on through that time, right?
One thing I like to ask all of my patients, if they've gone through pregnancies in the past, if they've delivered children, what was postpartum like for you? Because I think a lot of women, even from just an evolutionary perspective of survival, experience that postpartum, right? The first time you were separated from your infant, your brain, your nervous system is on high alert, right? And you have all these negative thoughts going through your head. And then in a way that's protective. That's helps us keep our children alive, right? But that is also hormonal, right? That doesn't just come out of nowhere. There's a lot of hormone changes that happen postpartum that mimic kind of perimenopause, and it can be a really good kind of predictive factor for what perimenopause is going to be like for you. And so, exactly what you experienced, right? And it's kind of this beautiful kind of symmetry that now you're also being separated from your kids and you're going through kind of very similar hormonal shifts. And so you're experiencing the exact same thing you did.
Yeah.
So that's one way to kind of predict.
Yeah, that's interesting. But it's true, when you think of it, they both are this little bit of, or a lot of a roller coaster, hormonal roller coaster.
Emotional.
Yeah.
I want to talk a little bit about hormone replacement therapy because I know that that's big question for everybody. But I also want to talk and speak to the fact that when you said everybody has different experiences with this, right? So it is really difficult. And I have to knock on something because I do feel not only that I don't think it's luck, I think I've taken care of myself and I do see this and I want to pound this home. If you're not eating right, hormones are affected by movement. They're affected by what our nutrients. They're affected by other things other than them changing and shifting. And I feel like people need to have that reminder, if you're not hydrating, if you're not eating well, if you're not moving, all these things can affect the severity of what may happen. But I also feel like you can't be afraid of doing what you need to do. And I know that I was one of those people because I have been very holistic thinking and lifestyle thinking and medicine, not that it scares me, but I think that it's usually the first thing that the first thing prescription is the way that medicine is going in this country. So of course I'm going to be a little bit what is the word I'm looking for?
Resistant.
Yeah, see, I'm losing words.
This is what we do.
Right? I mean, it's like simple words too, right? But like I am resistant to medication, and I know a lot of other people that feel that exact same way. They want to, and especially people that do take care of themselves. They're like, wait, I take such good care of myself. Why is this happening? And I don't want that medication, right? Whereas I do feel, after doing a bunch of research just on my own, that there is a place for it, right? Mm-hmm. And a lot of the information that was given were myths or were bad studies or bad information. So when someone comes to you and it says, like I actually had a doctor tell me that I'm too young to be put on hormone replacement. And I was like, wow, you have not done your research because you should know it's better to be on it younger than it is older.
Absolutely.
So, right. So there is that study that came out that kind of shifted everybody's thinking, but the healthcare system has not caught up.
No, not at all.
So talk to us about hormone replacement therapy and
yeah. So I appreciate that, because I think like most people do kind of want a quick fix. And I think what's happening right now in the menopause world is wonderful. Everybody's talking about it. That's awesome. But I think there's a lot of over-promising, right? There's this idea that like, oh, we'll just give you a little bit of progesterone, we'll give you an estrogen patch, and you are going to feel 25 again. Yeah. And you're not. That's just not realistic.
You're going to have abs.
And in the same way that, when you were let's say you were in your 20s and you didn't have PCOS, you didn't have anything going on, so you were balanced hormonally.
Yeah.
If you were in your 20s and you had really terrible lifestyle habits, there were still days where you didn't feel good, right? Mm-hmm. It's going to be the same thing with hormone therapy. It's not that you are now resistant to all of the other factors that contribute to how you feel. You still, even more so, need to be on the ball in terms of moving your body, in terms of putting good things into your body, because you just don't have the your body doesn't have the coping that it used to have to overcome that, right? Mm-hmm. You could overdrink in your 20s and have a very mild hangover for an hour and go about your business. Yeah. If you have a hangover in your 40s, you're going to feel it for weeks.
Terrible.
Yeah. Like I think alcohol is a great, a really big, factor to look at in terms of wellness in your midlife. Like we do not metabolize alcohol the same way. Yeah. And especially with everything coming out now, that whole myth that a glass of wine a day is really helpful. It's not.
Yeah. No alcohol is healthy.
Yeah. So I kind of got off topic there, but I want to
we like getting off topic. Okay. We do it all the time.
I love lifestyle stuff, and it is a very big part of my practice, and it's nice that I actually have time to incorporate that into my practice and to send people out to nutritionists and pelvic floor physical therapists and personal trainers, because I don't have any of that training, right? But okay, basics of hormone therapy. So everyone is scared of hormone therapy. Everyone thinks about it as this, very risky, medication. I don't look at it that way at all. Most women are able to safely take, the vast majority of women are able to safely take menopause hormone therapy. And when I have providers call me and kind of challenge me on that, I say, well, how much thought do you give putting a 42-year-old on an oral contraceptive, right? And most of them do not give it a second thought. Yeah. Right? They say, have you had a history of a blood clot? No? Okay. Is your pregnancy test negative? Great. Here you go. Right? Such higher doses. It's higher doses. It's synthetic, okay? And menopause hormone therapy is not only lower doses, but often it's bioidentical. And it's not that synthetic's bad, okay? I think synthetic kind of gets this, bad reputation. It just has a different side effect profile. And it does seem that when we look at, actually symptom response, the identical stuff is just better. Your body seems to like that the real thing. Sure. Yeah. And so your receptors are responding differently. And so with menopause hormone therapy, we can really target specific symptoms. So maybe you're in early perimenopause, what we call stage -2, and you're just having some insomnia and some anxiety. We can just give you a nighttime progesterone, and we don't even have to give you the estrogen. We don't even have to go there. We don't have to go to testosterone. We can do one at a time, whereas with an oral contraceptive, you're taking a synthetic estrogen and progesterone together. You can't separate them. Mm-hmm. So you just have a lot more freedom to give very good individualized care with hormone therapy. And again, there's no harm whatsoever in giving that to a 35-year-old. Because again, it's such lower doses than an oral contraceptive that we have no trouble giving. Right?
Yeah.
It's this very weird kind of backwards way of thinking that once I talk to providers about it, you can kind of see the light bulb going off and they're like, oh yeah, why am I weirded out by this?
Yeah.
Yeah.
But you do need to kind of get there because they're very uncomfortable with it.
Right.
Yeah.
So back up just a little bit and let's speak to the difference between bioidentical and synthetic.
Sure.
Those are the two options. Like if you go to a functional doctor, are they prescribing the synthetic or is it the bioidentical versus medical world? What?
Yeah, I don't think that there's necessarily like a split between functional medicine and kind of standard Western medicine. I think the Western medicine is more familiar with synthetics just because that's what's in oral contraceptives. That's what's in kind of the classic menopause hormone patch. And I think functional medicine, they really like compounded medications, which tend to be bioidentical. But bioidentical doesn't have to be compounded. So I don't really use a lot of compounded medications. I like using the FDA-approved stuff, the stuff that we kind of have better safety data on. And it's just more cost-effective for patients. Sure. So like you can go to CVS and get a $10 prescription for progesterone, or you could pay a $50, compounded progesterone.
Right.
But those are both bioidentical, and again, it's not that one's bad or one's good. It's just maybe based on somebody's specific symptoms or specific history, one is better than the other. I do try identical because again, it just works better.
Where does the bioidentical hormone coming from versus how are they making the synthetic? Is it lab?
Yeah, I mean everything's made in a lab. Everything's right, but the structure of that molecule is going to be identical to what's in your body versus it's going to have an extra carbon or an extra, whatever. Is getting a little bit into the weeds from what I can talk about, but so
and there's so much information. Like I've heard that it's from horses.
Yeah, so like CEE, cauda equina estradiol, that is made from the urine of pregnant mares, and again, that's a fine estradiol to use. That's not the one that I kind of gravitate towards or use anymore because we just have better options now. But that's how historically we were able to kind of produce these hormones in a way that we can give to people. And I think science has just come a little bit farther.
Yeah.
So we don't have to use the urine of horses.
I mean, that could make someone feel a little bit better.
Right.
Yeah.
So one of the things with hormone therapy that I always hear about is breast cancer. Yes. The risk of breast cancer. And I think that has been debunked for a majority of women. Can you speak to that a little bit?
Yes. It's like half my week. Yeah. So back in the early 2000s, the WHI came out and said, they stopped their study early, saying there is a statistically significant increase in breast cancer for women on hormone therapy, therefore we are stopping it. And overnight, millions of women stopped hormone therapy. Providers stopped prescribing it. I spoke with a provider that I work with. He's been in medicine for like 40 years. And he said he's still very traumatized from this because he felt like, oh my gosh, I'm giving all of my patients breast cancer. This was a very scary time.
Yeah.
And what we now know is that data was very misrepresented. The data itself is good. It's actually wonderful. We don't have a lot of randomized controlled studies for women in this country at all. And the data itself is good, so we can go back and we can look at it, and we have seen that data was misrepresented. So in the arm of the study where women got just estrogen, so they didn't have a uterus anymore, they didn't need the progesterone, they were on just estrogen, no increase in breast cancer. That's very well established. And you can kind of think through it. So do we see more breast cancer when women are pregnant, when your estrogen's high? No, we don't. Do we see less breast cancer after menopause when estrogen levels tank? No, we see an increase, right? So this never really made sense, but the media kind of ran with these headlines, and so now it's just this kind of ubiquitous myth that people still believe.
Yeah.
Now, where there's a little bit of disagreement still is that in that other arm of the study, where women were put on a synthetic estrogen and a synthetic progesterone, was there an increase in breast cancer for that group? Okay, and going back, and what a lot of even menopause specialists will say is that yes, but it was very small. It was 8 extra cases per 10,000 women. Super tiny, barely statistically significant, right? What I say, I'm kind of even further from that. If you actually go back at the data and you take out the women from the placebo group who were previously on hormone therapy, meaning they didn't say, only women in the study who have never been on hormone therapy can be in this study, right? They were testing 70-year-olds, 80-year-olds who were on hormone therapy in their 50s and 60s, but stopped for some reason. So if you take that group out, there's no more increase. So actually what that part of the study should have kind of prompted us to look at is, oh my gosh, is hormone therapy actually protective of breast cancer, right? Because it wasn't that the group who got the hormone was more likely to get cancer. It was that their placebo group was actually less likely to get cancer than the general population because so many of them had previously been on hormone therapy, right? That is such an interesting question that we just have not had time to it. We've lost decades of research
to the fear,
because of misrepresented data.
Yeah, and that happens all the time, unfortunately, in science. So that's why we're always like, well, science can be important, but it can also be something that you can't just look at one.
Right.
You have to open your mind and be a little bit more critically thinking and see what other studies are showing or what other research has been done.
Right.
It's interesting because estrogen in food, like soy, that information came out, and they also had a very misleading study with that.
Oh yeah.
And it's kind of interesting because it's very similar in the fear of what people have over estrogen.
And I think in general, unfortunately the wellness world is very prone to these kind of like knee-jerk kind of fear responses because it's very easy to do a study that's not designed so great, right? Or has a very small sample size. And it's very easy to then make a headline that can seem very terrifying, right?
Yeah.
And so I think there's some people who are being turned away from kind of wellness in general because they're like, well, every other week they're telling me that, this food is going to give me cancer and then this food's going to make me live longer. And it's back and forth.
Overwhelming.
I don't think we've figured out a very good way to kind of communicate the nuances of, research in general to a general population.
And sadly, and we talk about this a lot, that sort of then turns into, well, if nothing works, then I'm just going to do nothing, right? And I'm just going to eat whatever I want, and I'm just not going to move, and I'm just going to live with the way that I feel, which is really sad because there are so many things that can help, and there are ways that you can improve your overall well-being, and it's just, but you can understand, like we are all victims to it. We say all the time, like, you see on social media ads upon ads of things that are the quick fix because that's what people want. They just want to come to you and say, this is what's going on with me. Now I want you to do this. Whatever you do, whatever magic Megan does, like make me lose this 20 pounds that I've gained in the past year and a half, right? And I'm sure you're seeing that a lot. Women want to hear, how do I take this weight off that I've gained?
That's a question everybody has when I kind of walk them through their options and, what hormones might be helpful, what other medications might be helpful or whatever. They always ask, okay, well, am I going to gain weight or am I going to lose weight? What's going to happen? Yeah. And it's a very unsatisfying answer, but hormone therapy by itself probably won't change your weight by very much. Do I have women lose weight? Absolutely. I think it's a secondary effect, right? Yeah. Because now they're sleeping through the night. Their cortisol levels are lower.
They have more energy.
They have more energy. They're actually going out and exercising and doing all the things that they wanted to do, or maybe that was a habit before that they haven't been able to do since, they kind of went through this period of imbalance. So again, it wasn't the hormones necessarily. That helped open the door, but it was all of those good habits that they either had before and they were re-implementing or that they had since adopted. What tends to happen is that there's not really a change in weight with hormone therapy, but there is a change in shape, which I think is still really important. And honestly, like I think weight is a very poor indicator of health. I don't use the BMI in my practice. I hate it. It's trash. I think shape and kind of how you're feeling in your body is a much better way of kind of, navigating this topic. And a lot of women do see that now that we've kind of shifted their hormone ratios a little bit, that movement of body fat from the central stomach area to their hips, where that was kind of the more classic body composition in your 20s and 30s, kind of before perimenopause and menopause. So that doesn't change your weight, right? It's just kind of changes your shape and your composition. And then there's also the whole thing with visceral fat versus subcutaneous fat, which is another issue that I think a lot of people don't quite understand. But we see big changes with hormone therapy.
Yeah.
Again, timing, right? This is a time where women start to lose muscle. And if your muscle is going down and you're not strength training and things have changed, I feel like I talk about, I think all my stuff started in the pandemic. Not that we want to relive this or revisit it, but it felt like all that change was happening, and it was a time where going for a long walk in the woods felt better than going into a gym that was depressing because nobody could be there and trying to lift weights, right? So when I needed to keep on my muscle, I was burning tons of calories walking in the woods, not realizing what was about to happen in my body. So I think it was like the perfect storm for me. And I think that happens with women, that they don't realize that they're starting to get tired, so they stop doing as much exercise, and things are shifting. And like you said, joint discomfort is another one that I hear from women a lot. Like they wake up and get out of bed and just everything feels achy.
Joint pain is huge.
Yes. Yeah. Speak to that. Where does that come? Why?
We have receptors for estrogen and progesterone from our brains down to the joints in our toes. It's everywhere in our bodies. And there's a lot of evidence coming out. There's actually a whole name for it now, musculoskeletal syndrome of menopause, where your joints are just so starved, those receptors are so starved for estrogen, for progesterone, that there's inflammation and there's pain, and then you get into this high inflammatory state. Actually, one of the main symptoms that prompts me to start hormone therapy after 10 years from menopause, right, when it's thought to be more risky, is joint pain, because women are absolutely miserable. They can barely get out of bed, and they're like, I do not care if my risk is high. I want something that is going to make me feel better, that is not 3 different pain medications. I mean, one of the joys of my job is being able to take women off of these chronic meds that they've been given to manage these things that have been caused by hormone deficiencies. Right. And so joint pain is a huge one, and you're right. It is a reason why a lot of women stop lifting, stop strength training, because it just doesn't feel good anymore. It makes them feel worse. Right?
I wonder too, and I don't know if you've read anything or thought of this, but a lot of women in this age range are feeling this discomfort in their joints and their muscles. They're being diagnosed with muscular fatigue syndrome or fibromyalgia, or is there a possibility that it could be hormones?
Yeah, absolutely.
Yeah.
I mean, in addition to taking medications off, I'm also taking diagnoses off. So I'm taking diagnoses off their problem list. These chronic pain syndrome, chronic fatigue syndrome, these are all diagnoses that we have as a kind of a catch-all when we don't have an answer, right? I think I spoke on my Instagram recently about idiopathic urticaria, which is just a fancy way of saying, this person's getting hives all the time and we don't know why.
Yeah.
Very, very common in perimenopause. Right? It's just a response to these kind of wild swings in estrogen that we have that are causing your histamine levels to go up.
That's so crazy that you just, I literally the other day, I just said, one of my staff was saying that she was having I call her my staff. She's actually my friend, but she was having like, dry skin under her ring. And I said, oh, that's probably because the water is getting underneath your ring. But she was like, no, it feels different. It's, whatever. And I said, I don't know. I've never really had skin issues.
Yeah.
I put it out there, and I literally got out of the shower, and my whole like posterior side of my body was red and itchy.
Yeah.
And I'm like, what is going on? Like, I'm literally like, and I'm like, this is so weird. And now I've been, since that day, getting this like blotchy red, itchy, for no reason. And here you are telling me that, oh, another wonderful symptom of my age.
Yeah, I mean, if you're in your 40s or 50s and you've never struggled with seasonal allergies before, and now all of a sudden this time of year you are so uncomfortable, that could be why you're having this increased histamine response.
Yeah,
it's very interesting.
So when someone comes to you and is like for more like sexual dysfunction or low libido, do you
let's get into good stuff.
Yes.
Let's talk
do
sex.
you see, is some of this connected? Because I feel like some of it might be like trauma or past things that might be emotional things that people have to work through. Some of it, I'm assuming, is a menopausal hormone shift. Some of it obviously might be some relationship things. But how do you...
Some of it maybe we value sleep more than sex.
Value sleep. That's why we don't do it at night. We find in the middle of the day because I'm going to bed.
Right? We need to figure that out.
Yes.
We have to do it during the day.
But what's your kind of intake for people coming in with that
The intake is big.
Yeah.
Because I always like to say libido, female libido especially, is multifactorial. Like, it's hard to imagine something that couldn't kind of affect your libido, right? Like, if you stub your toe, like, you're probably not going to want sex for a little bit. Like, anything can affect.
How come it doesn't
female
work
libido.
The same way with men? Because they stub their toe and they're like, woo, you know what would fix that?
Yes, exactly. I could really get into the weeds with you guys with this, because there's whole theories of like sexual response cycles for men and women, and it's fascinating, and I love talking about it, but I can imagine other people would start to kind of doze off. But the reality for women is that it's just more complicated. And for men, it is more spontaneous. So we talk a lot about spontaneous desire versus responsive desire. So for women, especially for longer relationships and as we get older, it's harder for us to have that spontaneous desire, where we just are kind of walking through our house and suddenly we're like, oh, I think I would like to have sex now, right? Yeah. Usually it's more responsive. So our partners did the dishes this morning. Our partners did something nice for us unprompted. Our partner is giving us a lot of non-sexual touch.
Keep going, Megan.
Right?
Find more.
I'll make sure that all our husbands are listening to this episode.
Yes, I love doing couples visits. I love couples therapy so much because it's kind of light bulbs for both sides. And so that's kind of a more responsive desire. Even like, you might not be feeling aroused at the initial parts of sex, but during foreplay, you kind of start feeling it. That's responsive desire. And that's a nuanced conversation, because the message should never be just push through it, even if you're not feeling it, right? It's more, how can we create this environment that you're more likely to experience that responsive desire? And how do we not just slam the door because we're not feeling it right at the beginning, right?
Yeah.
So it's nuanced. But so the initial intake is literally looking at everything, looking at your relationship, looking at your habits, looking at your medications, your past medical history, looking at past trauma, which can be very difficult for some people. And it doesn't even need to be, kind of the more violent things that we think about as trauma, but what was your first sexual experience like? Was it like a little coercive? It wouldn't be something that maybe you would think twice about as trauma, but that's those kind of early sexual experiences, those first sexual experiences for us definitely play out in our future sexual kind of experiences. So that's always a very long and very, kind of sensitive conversation. And then we look at, where are you at in your life? Could this be a hormonal issue? Most likely we identify 3 or 4 primary kind of contributing factors, and we try and hit them from all different angles. So There are, of course, medications, but I really enjoy the therapies that are non-pharmacologic. I'm trained in Sensate Focus, which is amazing.
Can you explain that a little
Yes,
bit? Yeah.
I would love to. So Sensate Focus has been around for decades. It was first created by Masters and Johnson, who are kind of like the fathers of sex therapy, as a way to kind of like retrain your nervous system to thinking about sex as something that should be desired and should be pleasurable and something that's not stressful. So what happens for a lot of women is that sex becomes this very kind of heavy, stressful thing. Yeah, duty sex, right?
Yeah.
Feeling like you have to.
Oh, I've heard women say like they do it just so that their husband
Leave
won't go
them alone or something.
or won't go somewhere else.
Yeah,
for it,
exactly.
Which is
Yeah.
a sad
Yeah.
But very
truth.
common.
Yeah.
Right, very common.
And so what kind of can develop, especially when there's pain, when there's a pain response because of maybe dryness from perimenopause or menopause, right? Your body starts to learn that sex is something that actually it needs to protect you from. And so with that first kind of outreach from your partner, you're actually going to be kind of averse. You're going to tense up. Yeah, you just did it.
Yes.
Like with your shoulders. You're going to tense up. You're going to turn away. Maybe you do have a headache. Maybe your body is giving you a headache because it knows that sex is something bad and it wants to protect you from it, right? Whatever causes that can really kind of potentiate itself. And so Sensate Focus is a series of exercises that you can either do alone, so it's great for people with a history of trauma, and it can be done as a couple, which I also love doing. Great for couples who are coming back from a long period of sexlessness, who are just trying to kind of regain intimacy, maybe because of a tough time in their relationship or whatever. And it's a series of exercises that you do that's kind of blends mindfulness with touch and just tries to kind of reteach your body and your nervous system that, hey, touch to these areas is okay and it's pleasurable and it's nice. And it sounds a little fruity, but it works. And it's awesome. It's so gratifying to do when you have time to do it. Again, I can't do this in a 20-minute visit.
Right.
But when I have like an hour a week with couples, it's very, very helpful.
So as the practitioner, as someone that leads them through this, do you like verbalize and like have them move through some sort of like you lead and they follow type of thing so that they can eventually lead on their own out of it? Is that kind of like what your hope would be for someone?
Yeah. So
or
I
a
think
couple?
the hope, like if we're looking at, okay, we're going to do 4 months of Sensate Focus, right? We start very slow. Sometimes that's with taking sex off the table completely because we need to, not have that initial like, oh, this is really nice cuddling, but I know where it's going to lead. And so I'm starting to tense up. So we take sex off the table for a little bit. We work through the exercises. I kind of talk them through what's going to happen, and they do it at home a few times a week. And eventually we get to the point, I love actually when people come back and they're like, we didn't do what you said. We actually did have sex.
Yeah.
I'm like, great. You
Yes.
didn't listen to me. That means that it was good,
Yeah.
And eventually the idea is that they get to the point where they don't need to do these exercises. It just becomes, again, your body's starting to want it. Your body's into it now. We've retrained that nervous system. We've taken away that sympathetic response. And now they're just going about their life and they're happy and they never have to come back and see me again.
Yeah.
That's
That's
the joy.
rewarding too, is to like work with somebody and be like, you've now have the tools to like feel comfortable or quality of life or whatever it might be. And then are there some cases that hormone therapy can help a woman's libido and dryness and pain? I know sometimes with pelvic floor and stuff that's connected therapy to like some physical pain, but hormone therapy can help with some of this too for some people.
Absolutely. So testosterone's really big right now. Everybody's talking about testosterone. It's a great treatment for low libido. I use it a lot. It's very safe.
She doesn't personally use it a lot.
I mean,
Not yet.
yes.
Open to it in the future.
Yes.
She rubs it all over herself.
I bathe in it every night. And then vaginal estrogen cream is absolutely necessary if you've developed any kind of dryness from low estrogen. Often you use that with an estrogen patch or an estrogen pill just to get those vaginal tissues nice and healthy. There are medications kind of similar to Viagra for men, and I actually do use Viagra in women sometimes, that you can use kind of on demand, so an hour before sex, that can kind of help improve your response to.
Yeah.
And there are times where, we use both. There, again, I really like being able to get somebody to the point where they don't have to rely on medication for sex.
Sure.
But sometimes that's what's needed, at least as a bridge, as we kind of work through what's going on. Pelvic floor PT is often necessary because of, your pelvic floor is really just unable to kind of relax, or opposite problem. It's lost its kind of integrity and its strength. I treat a lot of vaginismus, which is actually like where the muscles of the vagina the outer third of it will just close and you can't have penetration.
Like when people say, I can't put a tampon in anymore.
Exactly.
Like, is that, yeah.
Yeah.
I've heard.
Often that's vaginismus.
Yeah.
That's a lot of,
I'm closed for business.
that's what's happening. Your body's like, nope,
Yes.
absolutely not. And it's very distressing. I have a lot of young women with
I know,
it.
I don't
Yeah.
mean to laugh at that, obviously, but
Yeah.
the way that you were just like, it's just closed.
Yeah.
No, what's hard is that a lot of women kind of internalize that there's something
Wrong.
very
Shame,
wrong with them.
like, and depending on like your spouse too, like you would hope that your partner is like understanding, but there is probably plenty of men out there that are like, I will go someplace, or make you feel like panicked of like, I need to either have sex and be in pain and just deal with it, or just like feeling like you're not giving your spouse what they want and they're not kind of working with you to figure it out.
Yeah.
I'm
It's
sure
definitely a hard male female thing, because men's like how much sex weighs with them versus how much it weighs with us, right? Like that must just be so much of what you see, like, because it can affect your relationship so much. But at the same time, like as a woman, you're like, it shouldn't, right? And as a man, the value of it is so much more.
Yeah, I think, and I do see the opposite too. I see women with the higher sex drive than the men, and I think that that's hard too, because it kind of is counter to what we kind of believe culturally. But yeah, I think anytime, we call it desire discrepancy. So you have one person who has a higher sex drive and they really value that. It's a big part of how they connect and find intimacy. And then we have somebody else who just doesn't need sex as much, and that neither one is right or wrong. But if you're going to have a successful, intimate, close relationship, you need to kind of figure out how to meet each other in the middle. And that's where sex counseling, sex therapy can be really helpful to help people get there.
Yeah. Yeah. The other question I had too is, what do you think about these trends of all of these subscription services for like hormones? And I've seen some like bigger names of people like being spokesperson or like saying like these are good. And I mean, I get that at the end of the day, people are making money and like a lot of that. But I've actually gone on before and kind of like explored around and did the quizzes and this and that. And I'm like, I don't know. I've not talked to anybody. How am I supposed to get somebody that I'm talking over? But like in moments of desperation, being like, I feel uncomfortable, or I feel these symptoms, or this is what, like, I just want to feel better. Like you like try to get that fast fix. And I think that like,
There's a lot of those.
a lot of times people kind of come to the thought of, because much of the medical 10-minute, 15-minute visits feel broken or feel like you're not getting like, everything looks fine, you look healthy, so you must be, or you're investing a lot of money that some people might not have into like a private practice to get more of that like 1 hour really thorough, which is going to give you so much. So like, I think a lot of people are like looking for something that's like fast and effective, but also not a waste of their time, if that makes any sense.
And they speak specific to your symptoms too. So of course.
Yeah. And great marketing.
Yes.
Yeah.
I think I would never blame a woman for going to any of these companies, because again, there's an access issue. There's not a lot of us with this kind of training. And it is very hard waiting 3 or 4 months for an appointment with your PCP or with a gynecologist, and you finally get there and they have nothing for you.
Yeah.
Right. So those exist because we have created this vacuum where there's just no help for women. Some of them seem to be a little bit better than others. There's one company especially that I feel like they're just going to have so many lawsuits that they're not going to be here in a year because the things that they are doing are so unsafe and crazy. And then there's other ones that if you have a very straightforward case of perimenopause or menopause, it's probably going to be fine. It's probably pretty expensive because a lot of them are using these compounded medications. But again, if that's within your budget and you've been suffering, you're probably going to get some help and you're probably going to get some benefit.
Sure.
If you have a little bit of a more complicated case, some of the big red flags we talk about with hormone therapy, history of a blood clot, history of a stroke, anything like that, they're not going to help you. History of breast cancer, they're not going to help you, right? That's where kind of seeing somebody like me, a menopause specialist who see red flags but kind of can think around them and beyond them, is going to be more helpful. Yeah. And safer too, right? Yeah. And I think one thing that's kind of scary about these is that there are women who are so desperate that it's very easy to lie with that initial, again, would not blame somebody, right? But they know that if they say that they had a history of a DVT, that they're not going to be provided their care. So maybe they don't put that. Yeah. And so then the person or the algorithm, right, that's prescribing to them gives them an option that actually is not safe for them. Yeah. Right. Yeah. So I think that's kind of where my fear is with these things. But I understand why they exist, if that makes sense. Yeah. No, I felt like I was hoping that you would say that because it doesn't make sense for quality individualized type of true care to me.
Especially us knowing the supplement industry like we do.
But also I get the desperation of being at home, and especially if you've tried things before, or gone to your PCP or gynecologist and been like, this is what I'm experiencing, and then you get sent home and it is. I mean, you then start to actually go crazy.
And also in line with that, you don't get sent home. So here's a scenario. How would you, how when somebody first comes into you, says that they went to their doctors and they got prescriptions for progesterone, estrogen, and that's what they gave them, no blood work, nothing else, just here's your hormone replacement therapy and good luck with that, right? Do you think that that's better than nothing at all? Do you feel that there should be blood work involved? Yeah. How do you deal with the prescriptive part of it?
Lab work is a very hot topic right now, kind of in my world, because, according to all of our major organizations, it's not required. And really, I don't need to do blood work to diagnose perimenopause. I can't, actually. That's not a way to tell whether or not somebody's in perimenopause. And it's not even that important for diagnosing menopause, right? Menopause is really just 12 months without a period. If you don't have a uterus, maybe labs are helpful. All that to say, whether or not to order labs is never a hill that I'm going to die on. And I think that we are in this space right now where we are kind of overwhelmed with health data, right? People are wearing Oura rings. People are wearing smartwatches, right? We know what's happening when we're sleeping. And I think that there is a utility in labs that can just kind of be very validating, for women. On the flip side, it can also be really invalidating, right? So if we order a bunch of hormone labs and everything comes back normal, how is that going to make you feel, right? Yeah. And I think that the person who has been tasked with kind of explaining these hormones to you is probably going to have the biggest effect on how you feel about that, right? And so I always talk through testing with women. I say, this is what the test can show us. This is what it can't show us. And we need to reflect a little bit on how are you going to feel if something comes back normal? How are you going to feel if something comes back abnormal, but I tell you that there's not really a reason to chase it, right? Because again, estrogen can have wild swings in perimenopause. And if it comes back really high, are you going to be really nervous about it? Even though I tell you I'm not nervous about this. Yeah. And I kind of expect this, right? Does that make sense?
The blood works moments in time too.
Yes. It's just so 1 minute in time.
Yeah. Yeah. speaking to that, push pause on this for a second when you said 12 months, because I've had a lot of clients come in and say, oh, nope, it's not 12 months anymore. I heard it's 18 months. It has to be 18 months.
Oh,
so
no.
do you feel like that's noise out there? And
Yes.
Okay, so
That's
it
noise.
is truly 12 months.
12
What happens if 12 months goes by and then you get your period again?
So we consider that postmenopausal bleeding.
Okay,
And
so it's not start over completely.
no,
So that's bad. That's myth.
it is.
Okay.
Yeah.
That's good.
And
Good
I haven't
information.
even seen like a few studies that are suggesting that we should change that.
Okay.
So that's interesting. I might need to go see what's out there.
Yeah.
But no, like I've had women who come in and they say, "Oh, I went 12 months without a period and now I'm bleeding again." And I'm like, "Well, I'm sorry, but we need to get an ultrasound and that's when we need to do some labs, you know, because I think where that comes from is that the data shows that after that 12 months, if there's bleeding, then you're more at risk for that endometrial hyperplasia. That's, by the way, what progesterone does. It helps protect the uterus from getting endometrial hyperplasia. That's why we have to give it when we give estrogen. And so, I don't know where that comes from.
Yeah.
That kind of worries me.
I've heard it a few times.
That really worries me because then you can have all these women who are having postmenopausal bleeding who are being told that it's fine.
Yeah.
Yeah.
And they're not getting care. That's scary.
Yeah. It's so, and of course, I'm getting closer to that 12 months. And and I'm hearing this from a lot of women that they're like, oh no, they changed it. It's 18 months now. I'm
Like, no.
I'm like, great. Thanks for the good news.
Fascinating.
Yeah,
Okay.
you should send her
Yeah.
something if you see it. All right, I know we're going to keep going. We can ask you a million questions.
Yeah.
I have two more things, quick things. When you get to that 12 months and you're like, I'm on the other side of menopause, do some of these really uncomfortable symptoms, like say someone didn't take hormone therapy and they just like wrote it out and then they got to that, can women anticipate having more of a calmer parasympathetic? Like I look at my mom and I remember her going through hot flashes and she got on hormone therapy for a year and kind of got over the hump of it and doesn't have those anymore, and seems like her quality of life, and again it's per person, is better, more comfortable. She's more comfortable in her body. So as someone who's going through such maybe an uncomfortable phase, can they look toward the future and be like, when this is over, somehow there's going to be something.
We're gonna
Is there a light
I'm
at
at
the end
12
of the
months.
tunnel?
Am I coming back to normal
Is there
now?
a light? I mean, when we talked to Nicole, she actually really was like, specifically for hormone therapy, but like hormones are really supportive for like she mentioned Alzheimer's, some different other types of health that like it's like people will be on hormone therapy long after they're out of menopause, more for preventative and supportive things for different areas of our body that our hormones do. But I guess separate from that, to that question of.
Yeah, and I think it depends on the symptom. So the symptoms that are coming from those wild swings in estrogen will get better because your estrogen is just going to fall and it's going to stay there. It's going to kind of flatline. Yeah. So the histamine response, that's going to get better. That's going to go away. Migraines, premenstrual headaches, things like that tend to go away after menopause. Okay, yay. Some other things are just going to progressively get worse if you don't intervene. So genitourinary syndrome of menopause, vaginal dryness, recurrent UTIs, recurrent vaginal infections. Every woman on this planet should be on vaginal estrogen, except for maybe 3 people with a very specific kind of uterine cancer. So everyone should be on vaginal estrogen to make sure that doesn't happen. Musculoskeletal syndrome of menopause might actually get worse because you're just constantly having inflammation. You're not moving as much from the pain, and things are going to get stiff, right? Osteoporosis. We know that hormone therapy prevents osteoporosis. So if you have a family history of that, if you have any factors that might lead you more at risk of that, you're going to see steady loss of bone mass. That's only going to get worse. So those things tend to cause a little bit less symptoms. Kind of the classic vasomotor symptoms, though, can be really unpredictable. I have a lot of women who come in and they're like, I feel like I'm going through menopause 2.0. I thought I was over this. Yeah. I went through menopause 6 years ago. I've been fine. And now I'm having these vasomotor symptoms again. I don't have a good answer for why that's happening. Yeah. But it does happen. And we get them on estrogen, they feel better. And to Nicole's point, yeah, I mean, I will be on estrogen until I die.
Yeah.
Right.
I was just going to ask you that. So this is hard for me. Like, I need to know there's an end game, right? Like,
Die.
and I think that die's your end game. I think there's a lot of people that feel that way. Like, I'm going to do this therapy, and this therapy has an expiration date. It's not forever, right? For me, I need to know. Like, so if I was your patient and you were working with me, and I am in I hit my 1 year, I know I still need this. Do we retest in 3 months and like sort of shift things? Is it a gradual, okay, we'll take you off this gradually? Is it what does that look like?
It's your goals. So if your goal is to be on this to just treat your symptoms until you kind of get through it, then that's what we do. And that's our plan. And so let's say you're 3 years into menopause and you're like, well, I haven't had any symptoms. I want to see what it's like coming off, right? And so depending on what your dose is, we might do a wean. We might slowly wean you off the estrogen. I would take you off one hormone at a time. I wouldn't just cut you off completely out of nowhere. We would do it very slowly, and we would see how you feel. A lot of women, even 10 years out, once they stop their hormones, they have a rebound of symptoms, and they want to go back on. Some women come off, they feel fine, and they stay off. I think it's all based on your goals. Like, if your goal is to really be as functional for as long as possible, then maybe being on hormones for as long as possible is part of your care plan.
So why do you say estrogen until you die?
Well, I will just be honest. I will be on hormones until I die because of just the very impressive data we have on the cardio protection, right? The number one killer of women in the United States is heart disease, all right? And I have women who, even with really good habits, develop heart disease, right? There's a lot of genetic factors that I don't think we quite understand yet. And just the loss of estrogen, right? All of our vessels get a little bit tighter, a little bit smaller, and there's just less room for error, right? So I think based on the bone protection, another thing that lands otherwise healthy women in nursing homes is a fragility fracture, right? And I think everyone who's been in primary care long enough knows a patient who they really loved, and they got a hip fracture and they died within a year. It's awful to see. It's terrible. I think for me personally, like, my long-term health goal is going to be as functional as possible, for as long as possible, to stay out of nursing homes. And based on what I have seen, that means unless I have a major event that is going to prevent me from being on hormone therapy, I will be on it as long as possible.
Yeah. So. It's just, to me, I see it like it's just science. Like, your body just stops producing something that, like, you can't change what your natural kind of aging and hormonal process. So, like, when it starts to goes away, dips, those things, you're not going to thrive in the same way if they're not there. Your body's not going to be supported. It's just not. So, like, you can't, like, think your way into that, like, thriving space. There's no, like, lifestyle practices that will make those things come back. It will make you feel better, but that's kind of how I think about it. Like, when we had, again, Nicole on, and you're just saying the same thing. It was like a light bulb moment. I was like, of course I would take this as long as I can, because it's going to support my overall health, which is what my ultimate goal is. Like, it's not like you're adding something that your body never had. It's like your body had this and then it went away, and then you're just putting it back in.
I'm going to play devil's advocate on that for just a second.
I know you are.
Yeah.
Yep.
Because I feel, and I probably will now do this, but I would like to research other countries and cultures, and it would be interesting to see, because we know that they don't have Western disease like we do. So with that being said, I feel like lifestyle plays a much bigger role than genetics plays in our disease prevention. So with that being said, the message still for me needs to be strongly that no pill, no therapy is going to help you to not have to live a healthy lifestyle. You need that foundation, right? And I also believe that if people wake up and realize that there isn't a quick fix and that they still need to focus on what they're doing in their life and how they're treating their body. The better you treat your body, the longer it's going to be better for you to get through things and live optimally and, have vitality and function beautifully throughout life. So I think that there's always going to be like people that are going to need it forever? Yes. There are people that are going to absolutely need help and therapies to get them to live better. But I don't want the message to be misconstrued that this is an option to not have to do this. Right?
Yeah, and
I
think that's like, I try to be very careful with my words when I'm talking to patients about preventative versus protective, right?
Yeah.
Those are very different words. So we know that we can prevent osteoporosis with this. We don't know that we can't say we can prevent heart disease.
Right.
We know that it's protective, right?
Yeah.
So again, if you're smoking a pack a day and you're not moving your body and you have all these other habits that we know contribute to heart disease, then the estrogen is going to be a little blip in that kind of mountain that you need to cross to lower your risk, right?
Yeah.
So I agree. I mean, I think I agree with both sides. I think it's your value system, and I think that's where individualized care really comes into play, right?
Yeah.
I will say, I've spent my life in community health, and a lot of the times it feels like I'm not fighting disease, I'm fighting poverty. A lot of my patients, they can't go to a gym. They don't have access to healthy foods. So for me, like, being able to I think it is so important that I speak with every single woman who comes in to see me at their annual physical from like 48 on about hormone therapy, because I already know that they are such at a disadvantage for all of this other stuff that we know helps, that they need to know how hormone therapy can help as well.
Yeah.
And that's a conversation that almost no woman is getting at her annual physical, because again, providers just don't know about it.
Yeah.
And that's why I give so many talks to primary care providers, because I'm like, we should be in the business of prevention.
Yeah.
We should be like salivating over, what hormone therapy can offer patients in addition to lifestyle.
Yeah.
So yeah, I think it shouldn't be one or the other ever.
No, and I agree with that completely. Like, my disclaimer is always, because I feel like listeners are holding on to something so strongly, especially when they're in the midst of going through it all, right? When everything feels heavy and they just want that fix, and they don't want to stop smoking their cigarettes, or, they don't want to go to a gym, which you don't have to go to a gym, even though I would love you to, but you don't have to, right? Like, moving our body. I mean, there are cultures that don't do organized exercise at all. They just move, and they are really responsible with their taking care of themselves by getting out there and walking to the grocery store instead of driving, or doing things that are going to help them to be a little bit more active. So I feel like if we don't say it, it's we didn't say it, right?
Oh, absolutely. No.
And that this is going to be this is what you do for this, instead of saying there is always going to be. It's like saying, eat this bar and everything else will be okay. Or if you put protein in your smoothie, then you don't have to worry about anything else you eat throughout the day. And that's not our message.
No.
Our message is, foundationally, you need to think about all the things that affect your hormones generally and that affect your health generally before you even can add all these wonderful things that now we have the opportunity to have experts that can help us with.
Yeah, definitely. So share if someone's coming to you, your private practice, what can they expect? How do they find you? Well, we'll link on your website and your Instagram, but what does a session look like?
So the initial consult, you get 60 to 90 minutes to just tell me your story, right? And we again do some of these very in-depth kind of history dives to figure out, is this hormonal? Is there something else going on? Do we need to do an additional workup? What's already been done? Everything. And then if we need labs, we do the labs. You don't pay extra for that. That's part of the initial price. And then I kind of create a care plan for you, and you can either take that home and just be like, okay, thank you very much. Or you can say, okay, I want to do this with you. And we do a 4-month optimization package that's almost like a concierge kind of model where you pay one price, and that is however many visits, however much lab work, like messaging me on the weekends, like whatever you need. I am here to help you reach whatever goal we have set for you in that 4-month period. Maybe that's hormone balancing. Maybe that's having sex that is not painful. Maybe that's boosting your libido, whatever. And again, based on kind of your goals, I might recommend that you meet with a personal trainer. I might pay for that initial consult with them. I might pay for your initial consult with a nutritionist or a pelvic floor PT.
Isn't that amazing?
Mm-hmm. It's ideally for me, like my vision was like, I'm going to have a space where we are all there together, right? And you just walk from room to room to room, meeting with everybody. But maybe
I've
in
thought
10
of that
years,
for years.
Yeah.
Trust me, that's been my dream.
we can all manifest it. For
We
the
can
future.
manifest it. Let's do it.
But for now, it's going down Main Street to meet with Alex at Boston Pelvic Therapy, or meeting you guys at Fit Life or something like that. And then after that, it's just we get you happy, and then you are just in a maintenance program, and I am there for you when you need me, as often as you need, and it's kind of like just a monthly membership.
I know it's insurance isn't covered for the sessions, but is it covered for prescriptions?
Yes, so you can use. So I am self-pay. Again, I could go on and on about how much I hate insurance companies. They don't pay for any of this anyways. So I am self-pay in the office, but you can use your insurance for medications.
Okay.
And I do have a lot of little tips and tricks for getting certain medications that are not covered by insurance kind of cheaply.
Okay.
So
perfect. Yeah.
Right. Would you look, if somebody wanted to come to you that has been working with their primary care or their OB, or would you be able to read their, like if they've already done all the workups, can they just bring those to you? Or
Yeah.
Okay.
And that's I think something that really I've really tried to distinguish myself, because a lot of these wellness clinics, before you even walk in the door, you are getting a laundry list of labs that often your PCP has already done, and so you're kind of paying like $600 for the just repeat stuff.
Yeah.
I do not order anything until I talk to you and look at what's already been done, and I'm not going to repeat anything. I'm not going to put you through a blood draw that you don't need. Yeah. So I encourage people to bring in whatever they have. We look through it, and we fill in gaps where it's needed. There's been one instance where I'm like, you really need a pelvic ultrasound. So I wrote a letter to their PCP saying, this is why I think that this is needed, and they're scheduled in a few weeks to get that done. So nice. I like collaborating, and I think that that's important, because if you go into your provider and you say, oh yeah, I met some girl and she put me on an estrogen patch and you have a history of a DVT, and they're like, what? I think it's nice to be able to call me, to talk to me, and know that I am credentialed in this. I know what I'm doing. I've had very complex hormone training, and I like having those relationships, and also being able to teach them something too. I think having a curious PCP is the best thing that you can have.
Yeah. Anything. We talk about critical thinking a lot, and like thinking outside the box and stuff.
Well, we think you are so valuable.
Oh my gosh, I could ask you questions all day long. Thank you for sharing with us, our viewers, our listeners. We will make sure that we put all the information in with the podcast and the post so people can find you. I'm sure that this sparked so much. And if people have questions, I do a Q&A on my Instagram every Wednesday. I always have people asking really thoughtful questions. It's anonymous.
That's great.
So, I mean, it's a great way to, even if you don't have questions, I think it's nice to just listen to what other people are asking.
A lot of times if someone has a question, like that could be your question too, that you didn't even know. Just to also, you do a great job with your social media.
Oh, thank you.
Yeah. Your branding and your how you do like the background, and you do a great job. It's like very pulls you in. So I know starting a new business and stuff like that.
It's the worst part.
It's the worst part.
I hate it.
Yes, but you're doing. I totally get it. Like I'm like always like I'm like ebbs and flows through it. But you're doing a really great job. It's like attracts me every time. Like I see something, I want to stop and like listen. And it looks.
I agree.
Visually appealing. So
Thank you. I cannot take credit for the branding at all. I had an amazing team do it for me because I have no training whatsoever.
They did awesome. Yeah. It's very appealing.
We all understand the struggle of social media posting. I'm like, oh, it's 2 and I haven't done it yet.
Yeah.
Right.
It's a job in itself.
Yes.
All right, guys, thank you so much for listening. You will be able to find all the information for Megan here and the post below. Reach out to her, ask her any questions. We can definitely connect you guys. Thank you for being here with us today.
Thank you, guys.
And we will talk to you guys real soon.
Bye, guys.
Thanks.